Are the lights the ones that to look in your eye? Are they supposed to be like the size of a pin?
They're not supposed to be.
Because I just got one at St. Home.
You got what?
I got one that I got it from Amazon. It was only $4. It came with 2.
Oh. So what was the question? The pen light what?
Is the pin supposed to be like a pin size?
Yeah.
Yeah.
Because
Yeah.
Oh, that's the rechargeable one. Yeah, you could change batteries on that one.
yeah, I got a second one too. It's pink too.
Aw.
It came
Yeah,
with
backup.
a whole kit.
No, it just came with 2. It was $4 on Amazon. I was practicing on my little dog just now.
All right. So where were we? I know I was trying to get breakfast. That didn't work out.
I'm waiting so I can get Chipotle.
Ah.
I'm hitting up yesterday's pizza.
It's Sushi Wednesday, guys.
I got leftover Don Carbon chicken.
How is that place? I haven't tried it.
It's good.
Yeah, I love that place. It's kind of pricey, but it's worth it.
Yeah, it is pricey. My dad liked it. I brought it one time to him because a friend of mine introduced me to Don Carbon, or the restaurant, the food. So I brought it for my birthday one year, actually last year. Yeah, it was last January. And my dad really liked it. And so for his birthday, we asked him what he wanted to eat for his birthday, and he wanted Don Carbon. And he really enjoyed it. So we started eating that. Well, when he had his heart attack, he couldn't eat very well. And so they were giving him...
Heartburn?
No, like pureed food.
Oh.
So it really didn't have any texture to it, and he was hating it and stuff. So my mom and I were kind of planning on getting him some chicken and whatever. And he was kind of up to the idea, when he was finally able to eat a little bit more, we're going to pick off little pieces and he could eat that. So for Father's Day, I went and I got him some chicken, and I know he could smell it and everything. And he's like, "Mijo, I can't eat it. It's too much for me. I can't eat it." So I was like, "Okay, Dad." So we called my uncle over. My uncle had to come from California to help us out with him. And so we called him over. We had lunch, and he was there in bed. And lo and behold, like not even 2 weeks later, week and a half later, my dad passed away. But at least I got him, we had talked about Father's Day, Don Carbon, and I got him his Don Carbon. At least he could smell it. So it's kind of bittersweet every time I go there. All right. So, like I was saying, we left off with the second 3, ABCs. And remember, we were talking about the rate, rhythm, and quality in vital signs?
Yeah.
Well, we're kind of doing that here as well. So the first one, airway. Make sure the airway's open. Ensure adequate ventilation. So you want to make sure that they have equal rise and fall of the chest. You want to look for any injuries. You want to maybe listen to lung sounds. and then put them on O2 if they need it. And that also includes breathing. Rate, rhythm, and quality of the breathing is full and effective, so adequate ventilation. You could also insert an airway adjunct here if need be. So we have airway, breathing, and finally circulation. We talked about the pulse, rate, rhythm, and quality, right? We're talking about skin signs. So that's the other thing. And the last thing in circulation is you want to look for and control any major bleeding. And that's important to remember, control any major bleeding. Because as I've told you a couple times, what's the good news about bleeding?
It will stop.
It will eventually stop.
Yeah, all bleeding will eventually stop. What's the bad news about bleeding?
It will eventually stop.
Yeah, all bleeding eventually stops. So good news, bad news, as weird as it is. Okay. So all bleeding eventually stops. Good news, bad news, all bleeding eventually stops. So, all right. Now the last point. So that was the second three. Pretty easy, right? 3, and then finally the 1. That's where we make our transport decision. Excuse me. In our transport decision, what we're basically deciding is it load and go or stay and play? Load and go means that we don't have time to mess around. Let's get out of here. Let's go to the hospital. Or stay and play. Hey, the patient's okay. We could play. We could use our tools, our toys. So that's how you think about it. Load and go or stay and play. Your transport decision. So let me erase that and open that and okay. So if you remember back, the primary assessment is to identify any immediate life threats. In other words, you want to look for and control anything life-threatening. Look for and control anything life-threatening. And what's the first part of that?
Make sure the scene's safe.
No, we're in the primary assessment now.
Oh.
Forming a general impression?
Your general impression. Okay. So, and this later reminds me of a call I had, but what's your general impression of her? Is there anything about her that's bugging you or making you go, oh shit?
The way she's looking at you?
That's bugging you?
No, maybe.
And no, she's not a tribal elder, so you don't have to worry about her.
Oh, okay.
Looks like she's giving you attitude like, why were you called here?
Okay. She's by herself, so it's safe to infer that she called you herself. Other than the RBF phase, or other than the RBF.
Her hand on her stomach?
She's holding her stomach.
Okay. So you're looking at what the problem might be. But again, the question is there anything about her that's bugging you? That's making you feel uncomfortable, that's making you go, oh shit, I need to get her out of here now.
No.
No.
Okay. That's what you need to be thinking about. Everything else is going to come along. That's just the general impression. Now, the other thing is she tracking you?
Yeah.
Yeah. So far we have a good general impression, and next she's tracking us. So in the level of consciousness, where is she at in the AFPU scale?
What?
Alert.
She's alert, orientated.
Good. She's alert and oriented. Well, we don't know if she's oriented yet. We'll have to talk to her. But right now, at least she's alert. Okay. The reason she reminds me of a patient I had was, it was an elderly lady, kind of her age. Well, I don't know if she's elderly, but middle-aged, who had been constipated for about 4 days, 3-4 days. And so what did she decide to do? She went all in. She was taking about 4 different laxatives. Well, guess what was happening all day long?
Shitting?
Exactly.
She's dehydrated.
Well, she was dehydrated, and now the laxatives have brought fluid in and caused her to get it out. Well, now at 3 o'clock in the morning, guess what?
She's still going.
She's all
She's still going. Still going. So she calls 911. She's been shitting all day, right? Well, at that time, I was in the EMT, and we did the transport for the fire department. Do you think this was an ALS call?
No.
No.
ALS.
No. And the medic, I don't remember his name now. It's been years, but he was a jokester. He was a cool guy. And he looks at me. He's like, "Have fun. It's all yours." I'm like, thanks a lot. But what else I remember about that lady though, and she was wearing one of those elderly muumuus. You know what I'm talking about?
The what? The gowns?
Yeah.
Okay.
But I call them elderly muumuus because it's usually the old ladies that wear them. So anyway, so we're gonna get her to the gurney, and it's a better visual when you can see it in person. So I'll have to do that to you or for you. But she gets a towel and she flicks it between her legs, and she grabs both ends. She's pulling up, so kind of a makeshift diaper, and she's kind of hustling over to our gurney to get on it. So. Okay. So I was driving. I didn't have to deal with her, but yeah, I remember that lady grabbing that towel and just flicking it between her legs. Oh my gosh! All right, so there's the AFPU we're talking about. Is he alert?
No.
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 Nope. So what do we do next?
Painful stimuli.
Pain
We're
stimuli.
going to use painful stimuli. One of my 2 of my former students, they're a married couple. She was in my EMR class or ECA class that I did at San Eli a couple years ago. And you know what she did overnight on her husband? She practiced the purple nurple on him.
Nice.
And she bruised him. That's why it's called the purple nurple.
Hey, maybe he liked it. That's why they're married.
Could be. Although I don't want to be thinking about my students being that kinky or kinky, period.
Weird.
Whatever turns you on, I guess.
Yeah, it's like I hear enough stuff, believe me. And mind you, I don't mind it. I really don't. So. Just checking out something. Okay. What else? All right. So if the painful stimulus didn't work, then what?
The now beds. Oh, sorry.
Actually, we went straight from unresponsive to, or we went straight from not alert to painful stimulus. Did we
Wasn't it
forget something along the way?
stimulus?
What was that?
Wasn't
Verbal
it
response.
the verbal stimulus?
Yeah, verbal stimulus. How are you going to do it?
Sir, are you okay?
Hey,
Mhm.
sir, this is so and so. I'm an EMT. What's your?
Well, he's that way. So first thing is
Oh.
you want to get him to see if he's awake. So yeah, just sir, open your eyes. I had a patient one time. He was a trauma patient involved in a motorcycle accident, and he'll come up later. And he was just moving about. He had his eyes closed. So I get there. I think I'm a battalion chief at the time. And I asked the guys, "What do you guys want me to help you out with?" I'm like, "Chief, can you just take care of the assessment? We're over here doing this." I'm like, "Not a problem." So I go up to the guy, "Sir, open your eyes for me. What's your name?" Doesn't open his eyes, doesn't respond to me. So I switched over to painful stimulus. And his reaction is not a good reaction. Crap.
Like a Narcan patient.
Nope. No, he was a motorcycle accident. He hit his head.
Deaf?
No, he wasn't dead. He wasn't dead.
Combative.
Nope. I mean, he was moving around a little bit, but no. What?
The adrenaline rush had him.
A what?
The adrenaline rush.
No. No, he suffered a brain injury. But I don't want to get too much into it now because we'll talk about it when we get into brain injuries. But he started to posture. In other words, he was doing extension, and that indicates a pretty good brain injury. The other thing I kind of noticed was a bulge in his pants. You don't want a bulge in his pants.
Priapism.
Mm-hmm. Yep. All right. So if he doesn't respond to a painful stimulus, then what?
He's still unresponsive.
Then he's responsive. Yeah. All right. We talked about airway breathing.
C-spine.
What was that?
So you just hold C-spine if he's just in case.
Yeah. Yeah, I got somebody on C-spine. We're going to be putting a seat collar on him. We got to get him packaged up, ready to go. And he's a significant trauma. What happened was he was riding a motorcycle, but he was passing traffic on the wrong side of the road. So he was just trying to zoom by everybody. Well, he comes to an S curve and he didn't make the curve. He went straight on. He was going too fast. So the front of the bike, remember we were talking about the collisions? So the front of the bike hits the stone hill coming to a complete stop. Well, there's no seatbelt on a motorcycle, so what did he do?
Eject.
He got ejected from the motorcycle, went forward. So here's his head coming right at you. Goes straight in, and with his weight and everything, brought the spine together and caused a significant brain injury. Where the last I heard, he was in a vegetative state.
Oof.
All for riding like an idiot on a motorcycle. That's why I don't have sympathy for motorcycle riders. So if you're one, I'm sorry, but don't jeopardize yourself or anybody else. All right, we talked about checking airway, breathing, and then circulation as well. So this is just a review, but controlling hemorrhaging. What kind of bleeding are we taking care of?
Major bleeding.
Major bleeding. Looking at this picture, is that major bleeding?
Yeah.
Yes.
It is?
No.
Well,
No.
prove it to me. I will take your word for it, but prove it to me.
There's no pool of blood.
Okay, what else?
It's not your main artery. No.
Okay. Well, the femoral artery's in there somewhere.
There's no tourniquet.
Okay. Oh, this was kind of pre-tourniquet days, but okay. The blood. Look at his pants. Is there a big stain of blood on his pants?
No.
No.
No. Is there a lot of blood dripping down his leg?
No.
No.
So I'm not convinced that he's having an issue. Are you convinced he's having a bleeding issue?
No.
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 She's
You
too
can't
calm.
Just put a band-aid on it and sit him on the bed.
Yep, pretty much. This next slide, I just love the way they caption it, and I mean, you have to find the humor in it. You guys ready?
Go for it.
Check for skin color. Ah, chingadera. Oh, too much. Check for skin color.
Your palms of your head.
Yeah, taking that question off your quiz. I see what you're doing, Sequoia. No, but the other part is, look at the humor in it. Check for skin color. Well, he's African American, right?
So do we put brown?
No, you're still looking for pink, warm, and dry. Because remember, those areas are pink no matter who they are.
Like if they're sweaty or they're moist or something.
Yep. And remember, there's areas that are pink on everybody.
Your eyes.
Yep. Palms of your hand, soles of your feet, in between your legs. All right. And then the last thing that we said in this 331 was your transport decision. And so load and go, stay and play. So load and go would be, and this is why I was trying to get the general impression thing straight with you guys, is a poor general impression will make a patient load and go. So if you said, oh shit, there was a reason why you said, oh shit. Okay. If the patient's unresponsive, there's severe bleeding or shock, signs of shock are load and go because the body is shutting down. Complicated childbirth, chest pain, severe pain. Now, for this next one, there's no right or wrong. Okay. I just want to hear your thoughts. Tell me if he would be load and go or stay and play. And again, there's no wrong answers. I just want to hear your logic. You ready? What do you think?
Looks like he fell.
Like what?
Looks like he fell. Like he's holding his arm. Maybe.
Okay, is he load and go or stay and play?
Stay and play.
Play.
Stay and play.
I mean, it could be load and go because he could have a fractured bone inside his arm and you don't know what's really going in there.
Well, what else?
He could have hit his head as well if he landed on his side.
Okay.
Impossible to have
Stay
a
in play 'cause he's holding himself up.
Could have
You know,
lacerated an artery.
Okay, so severe bleeding.
A
Okay.
closed fracture inside. What is it called? A green stick?
Maybe, I don't know. Need an x-ray. So, anybody go with load and go?
No. Well,
I would advise load and go, just in
Why?
case
just in case if he does have a fracture, if he does have internal bleeding, or if he would have
Okay.
hit his head, or
There's better be safe
depending on
than
the
sorry.
symptoms, I would advise it.
Again, there's no right or wrong. You can make an argument for letting go because isn't severe pain a letting go?
Yes.
Yeah.
Yeah.
The placement of the ladder is really bothering me because I'm like, realistically, if you fell off a ladder, would it be placed like that, or like would you be placed like that?
The adrenaline
Yes.
rush had him
Yeah,
moving.
On my couch.
Now, we don't know if he hit his head. Is he confused? So there's a lot of things, but that's kind of what you need to start learning to develop is your observation skills, and then start talking to the patient and figure out what's going on. All right. What else? All right. So next up, actually, so you guys that were mentioning scene size up before. So talk to me about scene size up again. What is it for?
What is the what?
Scene size up.
Safety. Scene safety.
Okay, but what's the purpose of it?
Safe to get off the ambulance, or it's safe to approach the patient.
Okay. So remember, the scene size up is done to determine whether it's safe for you to get out of your vehicle, and two, is it safe to approach your patient? And what are we checking for with a scene size up?
Penman,
Which stands for?
PPE,
PPE.
environment,
Mechanism
number of
patient,
patient,
mechanism
mechanics of injury, nature of illness,
response,
additional resources, and need for
need of
extractions,
extraction,
or C-spine.
Slash C-spine.
spinal
Okay.
cord.
And then after scene size up, what's next?
Mechanism will cause the injury.
Run that by me again.
Mechanism
Primary
will
assessment.
cause injury.
They can't hear you, Rosie. I can, but I don't know if they can.
Mechanism.
Okay,
cause
but we already said that MOI or NOI in the scene size up.
The primary assessment or
assessment.
initial assessment.
Okay. So the primary assessment. And in that primary assessment, why are we doing it?
To see this life-threatening situation.
To identify immediate threat of life.
Okay.
The 3-3-1s.
The 3-3-1. Yes.
Okay. And so what does that stand for?
General impressions.
Assess the level of
Determine
consciousness.
responsiveness.
Chief complaint.
Chief complaint. Meet life threats.
ABCs.
Assess airway, breathing, and
ABCs.
circulation, and transport decision.
And identify patient priority. Transport decision.
Okay, so we've got 3-3-1. General impression, level of consciousness, apparent life threats. Level of consciousness, and then chief complaint or apparent life threats. The next three is ABCs, airway and breathing. We're going to check the rate, rhythm, quality. We're going to go ahead and assess the adequacy of ventilations and listen to lung sounds. We're going to expose the chest, look for any type of injuries on the chest, and then check circulation. Circulation, we're looking for the rate, rhythm, quality of the pulse. We're also looking at looking for and controlling any major bleeding. And finally, skin signs.
Color, temperature, and condition.
What was that?
Color, temperature, and condition.
Okay. You can put that on there. Color, temperature, and condition. All right. And then the transport decision. What's the transport decision we have to determine?
Load and go or stay in play.
Okay. And what are some of the load and go criteria?
Unresponsive.
Poor general
Shock.
impression.
Chest pain.
Chest pain.
ear pain.
Breathing difficulties.
Any threats to your ABC.
Complicated childbirth. Right. So the transport decision is load and go or stay in play. Stay in play, we could stay in play with our toys. All right. So that was the primary assessment, or also known as the second slice of pie. How are you holding up?
Good.
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 Okay. Third slice of pie, you ready?
Yes.
The
Yeah.
focused, it used to be the focused system physical. Now it's the secondary assessment. So,
The body system.
what do you mean?
Axis affected by the body system.
Okay.
Cardiovascular, pulmonary.
This is where we're now doing our assessment. So we've done everything else. Now we actually get to do our physical exam. So looking at the outline, the secondary assessment is we're looking for anything else that the patient might be suffering from. Okay. So what we have to do, if you notice up here, let me expand it. Questions to answer. And that's what we have to do. When we get to the secondary assessment, there's going to be 2 questions we have to ask and answer. The first question we're going to ask and answer is it medical or is it trauma? If it's a trauma call, the next question we have to answer is it a significant or non-significant mechanism of injury? Now, what is a significant mechanism of injury? Anybody?
Like an oh shit.
Okay, what else?
A broken windshield on a car.
Okay. Anything else?
Be an accident.
What kind of accident?
NVA.
Motor vehicle.
What kind?
NVA.
Head on.
Okay.
Okay. There's
Rollover.
High speed vehicle collision. A rollover because a lot of forces are acting on the body. Ejection from vehicle. So when they said check the windshield, yeah. Is there a hole there that somebody could have fit through as they flew out? What about the death of a co-occupant? Why is that significant?
PTSD.
We're not talking psychological, we're talking physiological.
Did you say the death of a co-occupant?
No, we're oh yeah. No,
Yeah.
I'm trying to figure out why.
Maybe they could have been the cause.
No.
No.
No, Jennifer, what do you think?
I'm not sure.
Think about it. somebody in the car died. Your patient is not the one that died. So why is it significant?
Did someone die? He's not a patient.
Okay. But think about it a little bit more.
A burnout.
If it was significant enough for one of the people inside the vehicle to die, that could have meant that the patient could have some serious injuries as well.
Exactly. If the impact was severe enough to kill one occupant of the vehicle, maybe it was significant enough to kill a second occupant. So that's why they're let and go. And I did have a call where occupant, the driver, died in that accident, and his wife was right next to him, and we took her as a trauma. But we think he had a heart attack as he was driving. I think she was okay. All right, falls greater than 15 feet, motorcycle crash, because again, you're not strapped in, you don't have a lot of protection. Patient is unresponsive, altered, or any type of penetrations to the chest, head, or abdomen, kind of vital areas there. And then for kids, falls greater than 10 feet or twice their height. Bicycle collision, and then instead of a high-speed vehicle collision, it would be a medium-speed vehicle collision. Okay.
You
All
said
right.
greater than 10 feet or what?
Twice their height.
What were the last two, Lou, that you said for the last one, for the significant mechanisms of injury after a motorcycle crash?
Besides motorcycle?
The falls greater than 15 feet?
Unresponsive or penetrating injuries to the head, chest, or torso. I'm sorry,
okay.
abdomen.
Got it, thanks.
Okay, so that's significant. So now what you're going to do is you're going to do what we call a rapid trauma assessment.
That's number 3?
Huh?
That's number 3?
What do you mean number 3?
No, it's still part of the secondary, correct?
Mm-hmm. I was just saying that there's 2 questions you have to ask and answer. The first one is a trauma or medical, and the second one, so our answer to the first question was trauma. So now we have to ask and answer the second question, and that is it significant or non-significant mechanism of injury? And we determine it's a significant mechanism of injury. We'll talk about the death of a co-occupant, okay? So we want to do the exam, the physical exam that we do. In other words, we are actually going to touch our patient. And so the exam that we do is a rapid trauma assessment.
This is still through trauma, right? With the
Yes,
trauma.
we're still in trauma.
Okay.
Now, the rapid trauma assessment is a very quick head to toe. I already know what you guys are going to ask, so I'm not going to beat you guys to it.
I'm sorry, what was it called again? Rapid what?
Trauma assessment.
Thank you.
Chihuahua. I do my keyboard. Of course, it's way back there. So I hate this keyboard. I can't see.
That's trying to come up here.
All right. So in the chat, I just sent you, or sending, the definition of a rapid trauma assessment. So I know you guys are gonna be like, can you repeat that again? Can you say it again? Can you go slow? Rapid trauma assessment. A very quick head to toe exam, lasting no longer than 60 seconds. Looking for and controlling anything else life-threatening that we didn't catch in the primary assessment. Now, to help make it make sense, where are we concentrating when we're dealing with the primary assessment?
The interior of the body.
Now get back on camera and show me.
The front of the body.
There's more to it than that.
The AB,
Remember I showed you guys,
airway,
and I told you guys, huh?
the airway and all that.
I need to get uncomfortable to be able to show you guys. Anybody else want to try and share?
The head, the chest, and the abdomen.
Nope. I showed you guys.
Is that when you had it like from the head to the mid chest?
Mm-hmm. From here to here. That's what you're concentrating on. Okay. Is that very limited? It is.
Yeah.
Very limited. So can we maybe not find something that's life-threatening in that because we're not really checking the whole body?
No.
Yeah. We want to check the whole body. And I'm going to tell you where you could find areas or injuries that are really going to affect the patient. Okay. So first of all, remember, it's a very quick head to toe. Is the brain going to be maybe affecting life?
Yes.
Mm-hmm. Gloved hands. Pretend like your hands are gloved. Start at the back of the head. Remember I said head to toe. You go forward, you're feeling it, you look at your hand, see if there's any blood. What you're going to be looking for is decap BTLS. And you guys should be able to see it on the screen right now. All right? Right there. Decap BTLS. You see it? On your screen?
Yes.
Yes.
Yeah.
Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. All these acronyms we've gone over today, you need to learn them. Flashcard, repetition, put them in your memory banks. After that, you could check the face. You want to check the trachea, the neck. You check the trachea, make sure it's in line. It's right down the center. You're going to look at the neck, at the side of the neck for jugular vein distension. The jugular vein swollen up. Hopefully you already did, but if you haven't, you need to expose the chest and visualize that chest, looking for any type of, again, decap BTLS. They could have a flow segment. They could have paradoxical breathing. You go, and then on the chest, what you're also going to do, and again, it's easier when you're in person, you're going to squeeze in on the side of the chest. We call that barrel hoop. We're checking the stability of the rib cage, and then you're going to press down on the chest. Then on the abdomen, see my abdomen? And again, you're looking for decap BTLS. The abdomen, you're going to palpate all 4 quadrants. So you take your hand, and you could use both too, and you're going to roll it over the abdomen. Okay, all 4 quadrants. Again, you're looking for decap BTLS, but you're also looking for distension, where the abdomen is getting bigger. Right at class last night, I kept doing that, and I started yawning.
It's contagious.
It is. The Mythbusters proved it.
Done.
So distension. Rigidity. Is it rigid, stiff, rock hard abs? Pulsatile masses. When you're pressing down on the abdomen, do you feel something pulsating? Like with a heartbeat. Now, when you're assessing, I told you you roll it over the abdomen. Don't just be doing this kind of stuff with your fingertips. That's not an assessment. That's an assessment. I see you got out of San Francisco and you went to Halo or something.
Yeah, thought I would change it up.
How do you do that?
Press the 3 little dots on your screen, and then it'll say change background. And then you just apply it.
Next up, you go to your pelvis. Get the pelvis, squeeze in from the sides. Again, that's barrel hoop. You're checking for the stability of the pelvis. And then with the heel of your hand on either side of the wing, you're going to press down. Don't do that on little kids. You could actually break their pelvis if you do that on little kids. Only do it on adults.
Do you do that to a patient who's fallen off a ladder? Is it safe to press on them?
Mm-hmm. Because you're trying to determine whether their pelvis is stable or not, especially if they fell on their butt. And then you go down the lower extremities. You want to use counter pressure. Don't be going down and just feeling it. You want to put counter pressure. Looking, again, for decap BTLS, but you're also looking, if the patient is conscious, you're going to be looking for PMS, pulse, motor function, sensation. We'll talk about that later. Go to the next one. Again, you're going to palpate it. Go to the upper extremities. Again, the counter pressure. So here's my twiggy arms. So I'm going to press on opposite ends because I'm checking to make sure that that bone is stable. If I'm going that way, going this way, and I have a lot of movement, then that pencil is broken or that bone is broken. So do it on both sides. Again, check PMS. Okay.
What was PMS again?
Pulse, motor function, and sensation. So you notice they're assessing him. Here they're choking him out. You're not filling up his chest or his man boobs. Okay, those hands should be lower. Want to squeeze in, one hand press down the center of the sternum. And if she's a female, you definitely don't want to be feeling her up. Checking the abdomen. Remember, you want to roll your hand. Don't just go little by little. Checking the abdomen. And then they're going to log roll them. Although it should be done after you check the extremities. Log roll them and check the back. Kind of doing counter pressure. I still don't like it. Now you notice. Here's a good picture. Yeah. You notice right there, he's down to his shorts. He still has socks on. Although, we'll pretend that those shorts are skivvies. And it's what we call trauma naked. Significant traumas. The guy appears to be unresponsive. We need to strip them down to their skivvies, down to their underwear, to be able to visualize the entire body. Socks. Out.
Do you cut them off or do you take them off?
You should cut them off. However, because I tend to be too nice, I take them off. Believe me, it pains me when I have to cut off clothing, especially like the biker jackets.
Mm-hmm. Oh, they're expensive too.
Yeah. So I try to be considerate of that. I've cut off underwear. I've cut off bras. I've cut off leather motorcycle jackets. I've cut off pants, jeans, t-shirts, all sorts of stuff.
Or the females get mad when you cut off their expensive bras.
No, but well, actually, I have one.
They're Victoria's Secret bras.
No, it was I think like the JC Penney special.
Damn.
Oh, they weren't expensive then.
Now I have no idea what you're talking about with Victoria's Secret.
All of a sudden, the guys are quiet now.
I know.
No, don't get me started. I'm gonna stay out of this
Oh,
conversation.
there you are. Someone's awake.
At least he's awake. Oh, shoot.
that we know of. He doesn't have his camera on, so.
Yeah.
There's only 3 people that I've noticed have their cameras on.
Maybe
Lucas
turn mine
always
on.
has his on. Rosie, because I asked her to. And Sequoia.
Still no comment? Guys being quiet? Okay. Oh, if you bring alcohol,
Stay quiet.
Are guys supposed to comment on Victoria's Secret?
Hey, well, I wouldn't cut no Victoria's Secret because that shit is expensive,
Yeah, that's really expensive, man.
and I like seeing it on women. So
I'd make a comment, but I'm the teacher, so I can't.
No.
especially the
you're
ones that
there
got the
checking
clips
the
up
polls?
front.
Hmm?
Nothing.
Say it. You already said it, so say it.
That's better, especially the browser that have the clips up front, that easy access. Oh my god.
A buddy of mine taught his son when he was a preteen how to take off bras with one hand. You know where he showed him? At the mall. He would take him to the mall with the mannequins that had the bras on,
Oh,
and he would show him how to take off the bras with one hand.
Why wasn't he my dad? Gosh.
It's a good skill.
Yeah,
I
wish he
mean,
was
talk
my
about a
dad for
good
real.
dad. Teach his son like the essentials to get by in life.
I'm gonna
There's
teach my
no-
grandson that.
There's different bras now, so they're more harder to take off than they are to put on.
Yup.
Does the practice?
They did that for men.
Anyway, before I get myself in trouble. So, checking something. Pulse, motor function, sensation. Again, if the patient's unresponsive, they can't follow your directions to be able to wiggle your hands, wiggle your toes. Can you feel this? Can you feel that? But you can check for a pulse. That's good. That's about it. All right. So that's a significant mechanism of injury for trauma. You do a rapid trauma assessment, which is a rapid head to toe exam lasting no longer than 60 seconds, looking for and controlling anything else life-threatening that we didn't catch in the primary assessment. Now, I told you I would tell you what's life-threatening. Remember, we've been talking about blood volume. The average adult has how much volume in their body?
3 liters? 5, sorry.
5 liters of blood.
Oh, I thought it was 8.
On the average, is 5. Yeah, some more, some less, but we'll use 5. So 20% blood loss is 1 liter, right?
Yeah.
Okay. And remember, in the primary assessment, we're concentrating up here, not the rest of the body.
Right.
If your patient, you discover the patient has a fractured femur, one femur can lose between 750 to 1,000 cc's of blood. That's one femur. So they can lose 20% of their blood volume as a result of that fractured femur. Is that a good thing?
No.
No. Now, Rosie was mean, so she broke my other leg, my other femur, to teach me a lesson.
Good job.
Hey. You're not supposed to be congratulating her for beating me up.
Wow.
Yeah, Sequoia, take it easy.
She's antsy. I can tell you're antsy.
I'm hungry.
Me too. I didn't have breakfast. That's why you see me snacking on tortilla chips. I did get a chance to go to the gas station to get some Monsters, and I went to McDonald's, but there was a long line, and I only had like 4 minutes. I'm like, I'm not gonna get through here that quick. So.
Well, I got my Chipotle, but I'm just waiting to eat it.
In other words, you don't want us to see you eating your chipotle.
He's chasing it with the beer.
I don't eat there very often. Actually, since I've been in Texas, I've never eaten at a chipotle.
Really?
Yeah. I did a couple times in California, but that was about it. Maybe like twice.
I'll eat it once in a while, not all the time.
Isn't that the place that got everybody sick a few years ago?
Yes,
Yeah.
exactly
Yeah.
my point.
Big old lawsuit.
Wow.
Exactly. All right. So going back to the assessment.
I'm hungry
So, well, we're almost done. So the other part of the assessment. So we talked about rapid trauma assessment because I was talking about the femur. So Rosie really wanted to punish me, so she broke my other femur. And so now, if one femur is 750 to 1,000 cc's, what's two femurs? 750 plus 750, or 1 plus 1, or 1,000 plus 1,000 equals?
2,000.
2,000.
Yeah, 1,500 or 2,000 cc's of volume. So two liters of 5 is what percentage?
40%.
40%. That's stage 4 hemorrhage. That's not a good sign because there's only 4 stages. So you see the problem with that? So bilateral femur fractures are also load and go criteria. Now, the pelvis. Fractured pelvis can bleed between 1,500 to 2,000 cc's. Good to know, huh?
Yeah.
Because what percentage is that again? Yeah, just like before, 40%. So can you see the danger of having your bilateral femur fractures or unstable pelvis? So those are trauma criteria. Those are load and go situations. Remember, we concentrated further up. That's why we didn't catch that stuff. Now, because the secondary assessment, or the purpose of the secondary assessment, is to look for and control anything else life-threatening. All right, you guys with me there?
Yeah.
So that's why we have to be thorough. All right, the answer to the second question now, instead of being significant, it was non-significant. So this time, Rosie grabs Paul in the wrist lock and really hurts his wrist. And we go out and we assess his wrist. Do we have to do that rapid head to toe on that wrist?
No.
No.
So the way to think about it is, because it's the type of assessment that we do now is a focused physical assessment. In other words, we're focusing in on the injured part. His only complaint is that his wrist hurts. And all we're going to do is just concentrate on that wrist. All right. So, all right, where am I at? So trauma, first question is trauma or medical, and it was trauma. Then it was significant or non-significant. Non-significant would be, we talked about, so what kind of assessment we're going to do?
Focus assessment?
Nope.
Rapid.
A rapid trauma assessment because there was significant mechanism of injury. If it's not, then what?
Focused.
Focus.
Focus history.
The modified secondary assessment?
Yep. We're just adapting to the injured body part. So in this case, Paul's wrist. Excuse me real quick. Hello? Hi. Hi. Is this about my timesheet?
I was about to say, we could hear you.
He's in trouble.
Yeah. I had to mute him real fast.
Was everybody getting this chapter?
It's a lot of information.
Slowly but surely.
For sure, the assessments are on the international.
So I'm sure.
Oh, I found myself. All right. So we're going to focus in on that injured part. We could do the PMS. We're going to look for deformities. Again, looking for decap ETLS. So, all right. So any questions on the trauma part of the secondary assessment? Okay. So let's go back to the first question. And this time, instead of saying answering it with a trauma, we answer it with a medical. So now the second question we have to ask and answer is, are they conscious or unconscious? If they're unconscious, can they tell us what their chief complaint is?
No.
No. So what we always have to remember before we go down the medical track is we have to rule out trauma. So they can't tell us what's bothering them, so we need to look. And according to the outline that you guys have, what is the name of that assessment that we do?
What was the question again?
I don't know.
A modified second assessment?
I think I just had a petite mal seizure
Primary survey.
or an absent seizure. Huh?
The primary survey?
No, we're not at the primary survey. No, I wanted to know what is the name of the assessment that we do when the patient is unconscious. We need to find out whether this is trauma related or medical related.
Trauma.
Decap?
That's what we're going to be looking for. We call it a rapid medical assessment.
Wow.
Rapid medical assessment. And how does that rapid medical assessment look like?
Palpating.
Okay, we'll palpate.
Visualizing, looking, any lacerations, punctures.
Okay. Let me make it simple for you. The rapid medical assessment looks just like a rapid trauma assessment, except we call it a rapid medical assessment now. So you're literally doing another head to toe exam. Looks just like the rapid trauma. All right. So same thing, decap BTLS, you go to the head, work your way down, all that stuff. All right. So the next part of it is if the patient is conscious, they can tell you what's wrong, right?
Yeah.
So earlier, our patient Rosie was complaining of shortness of breath. So can we focus in on her shortness of breath?
Yeah.
Yeah. Yeah. And so how does that change anything?
You just concentrate on her breathing, or my breathing.
Mm-hmm.
So
Yeah. Now this is where we get to PQRST or OPQRST, as you mentioned earlier. Right. There was the focus trauma assessment. OPQRST onset.
Sample.
No, we're not doing sample yet. So the OPQRST is a part of sample, signs and symptoms, but we're going to do OPQRST onset.
what?
How long ago did it start, or what were you doing when it started? Now, what I don't like, and a lot of people don't like about OPQRST, is there's some redundancy. Okay, because what you do when it started, provocation. Although you could also say, has anything made it better or worse? Q is quality. As far as how are they describing the pain or the discomfort? R, radiation. Does it go anywhere? Relief. The region of the body, and finally reoccurrence.
Can you say that one more time for me? Radiation relief and
Radiation relief, region, and reoccurrence. S is severity.
How bad?
Mm-hmm. On a scale of 1 to 10, 10 being the worst pain you've ever felt, what would you put it at? If a female tells you the pain's a 10, be very delicate about it, but ask them if they have kids. Don't just assume, oh, so when you had kids, what do you mean? You calling me fat? Landmines. Ask them if they have kids. If they say, yeah, okay. So how that pain, how does it compare to childbirth? Is it the same, better, or worse? Because remember, you're having them compare it to the worst pain they've ever felt. And for most women, the worst pain they've ever felt was childbirth. So I have them compare it to childbirth. And say, oh, no, it wasn't as bad. Okay, then obviously it's not bad. And remember, everybody's pain level is subjective. For the ladies, you could tolerate a lot of pain. For a guy, and all the guys in this room can attest to this, when you wake up in the middle of the night and you stub your little toe of your foot on the bed,
Oh,
isn't that
still
worse?
like a mother.
Yeah, it's horrible. It's horrible. That's about a 10. So
I had a kidney stone, and that was definitely a 10. That was horrible. Felt like I was having a baby.
I had
Did
two
give birth
broken
to a stone.
pieces.
All right. And then the T is time. So
Time.
again, can you see the redundancy with the O? Yeah, T is time. So there's some redundancy. So later on, we just drop the O, and it's just PQRST. Okay. The other thing we have, which is what you see on the screen, is sample. Signs and symptoms, allergies, medications, past pertinent medical history. last oral intake, and the events leading up to the incident. Okay. This is where I say don't be a robot, because I've had EMTs and students that will be like, okay, so are you allergic to medicines? What medicines do you take? What pertinent medical problems do you have? It's like the patient doesn't freaking know what pertinent means. When was the last time you ate? And what were you doing when all this started? It's like, why do we need to know the last time they ate? Abdominal pain, maybe, or definitely. But for other things, no, we don't need last oral intake. I just go with the flow. I go with the flow. So sample history. Signs, symptoms, allergies, medications, past pertinent medical history, last oral intake, and the events leading up to the event, or the events leading up to the incident. Okay. So that's your sample history. We've talked about vital signs. You could do vital signs anywhere along the way. I recommend it. I told you guys this. I recommend that you do it right off the bat. The other thing you're looking for as you're doing your assessment is any type of medical bracelet, tag, necklace.
Tattoos.
Yeah, but the one discussion that I've heard of about tattooing things on yourself for your medical wishes is that it's a HIPAA violation. I don't know how, but that's what I've heard. If we come across an unresponsive person and we don't know what's going on, we want to look for medical alert tag, like that bracelet right there. It will have maybe their name, it will have a phone number to contact, or have their medical record number, and we can call that number and they'll give us information. We identify ourselves. I'm Lou Ortiz. I'm paramedic with Sierra Blanca Northern County EMS. We have a patient here. They're wearing this bracelet. They have this. Can we get further information, please? Okay, they'll give you the information. So look for things to help you out. Okay. All right, we've talked about respirations. We've talked about skins. All right, so questions on the secondary assessment.
No.
That's where the outline will help you. You have two questions, and I apologize, we're not in the classroom, and I wish I could, and I don't have my dry erase board here, but I wish I could write it out and kind of show you the flow. But it's real easy. We have trauma, then significant or non-significant mechanism of injury. Significant, we go to rapid trauma, and then we go to vitals if we haven't done them, and sample history. If it's a non-significant mechanism, then it's a focus, history, and physical exam. We're just focusing on that area. Whereas if it's a medical, are they conscious or unconscious? Unconscious, we do our rapid medical assessment. We're trying to find out why they're unconscious. And then again, signs, symptoms, or sample, and maybe a PQRST. Or if they're responsive, they can tell us what's going on. We can actually go down and say, okay, they're dizzy. We'll concentrate on that. OPQRST or sample, vital signs, the whole 9 yards. Okay. That's the secondary, where you're actually assessing your patient. You're putting hands to patients. Okay. So, question on that?
No.
All right. So the last thing we're going to do is our reassessment. The purpose of our reassessment is to determine whether the patient is the same, better, or worse. Is the patient the same, better, or worse? The way we do that is we're going to reassess, first off, their vital signs. We're going to reassess our treatment, or our interventions. We'll reassess our transport decision. And we will reassess vital signs, interventions, transport decision. That's it. And what's the purpose of the reassessment?
To see if you're
See if
doing
the
better.
patient is the same, better, or worse.
Any changes?
We're looking for changes. Yes, we're looking for changes. So the way we do that is if the patient is unstable, in other words, the poor general impression, if they're let them go, they're unstable. And so we're going to reassess them every approximately 15 minutes. Okay. Wait, what did I say?
It should be every 5 minutes, shouldn't it?
Yeah, that's why I'm like, wait, it doesn't sound right. If they're unstable, so let them go. We're going to reassess them every 5 minutes. Every 5 minutes. We want to see how they're doing in transport. We're going to make sure they don't deteriorate. As far as a stable patient, they probably don't have much wrong with them. So we're going to reassess them every 15 minutes. So a stable patient is reassessed every 15 minutes. Okay. All right. And that's it. Just commercial exams, initial assessment. And then we get to the hospital, we transport, or we turn over the patient, but that's not part of the patient assessment. So with the reassessment, that's the fourth and final slice of the pie. So you see how we cut it up into manageable pieces? Pinman, 331. The secondary, yeah, can get a little complex, but it's just answering 2 questions. And knowing significant, non-significant. Rapid trauma, focus, history, and physical. Medical. Conscious or unconscious? Conscious, medical. Unconscious, head to toe. Try to find out what's wrong. Okay. So, what else? Any questions?
No.
Did this make sense? Did this help?
Yes.
Yes.
Yeah.
It took a while to answer. So you need to memorize it in a organized manner. Now, you start getting used to what you're checking. But when the next time I can't talk. The next time we're together, I want you guys to just have conversation with your patient. Okay? Luis, I'm going to pick on Luis now. Luis, you're my patient. All I'm going to do, notice, I'm just having a conversation. And just kind of talk through things. Hi, sir. My name is Lou. I'm an EMT. What's your name?
Luis,
Luis. What's going on today, Luis?
I have pain in my stomach.
You have pain in your stomach. Okay. Paul, can you go ahead and get me a set of vital signs real quick? Now, Luis, when does pain start?
This morning,
This morning? Okay. What were you doing when the pain started?
I was just exercising a little bit.
You were exercising. What were you exercising?
My core, yeah, the abdomen.
Okay. All right. So you think you might have strained a muscle in your abdomen while you were working out?
Yeah, it could be, possibly.
Okay. Have you had any problems going to the bathroom?
Just a little bit.
How so?
It's hard to use the restroom.
Number one, number two, or both?
Number 2.
Number two? Okay. Has that been happening for a while now, or is that since this morning?
Just since this morning.
Okay. All right. And so that pain, how would you describe that pain to me?
Around like a 6. It's sharp. It's a sharp pain.
This is sharp pain. Okay. Is it okay if I touch your abdomen?
Yeah, go ahead.
Okay. So I'm gonna go up. You notice how I'm just conversing with him? Am I being a robot to him?
No.
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 Do you hear the tone and the reflection in my voice?
Yeah.
Yes.
Okay. Shows concern.
What's my train of thought? You're like showing compassion or like sensation.
Mm-hmm. Maybe empathy a little bit.
Yeah.
Yeah.
The other thing too is, did you notice how I was going after the PQRST?
Yeah.
I went off on a little bit just to try to get some more information, but I went back. I asked him what he was doing, and he said he was working out. What area? I started going into that. So I'm using the OPQRST as a guideline to help me try to figure out what's going on. Now, it could be muscle strain, but if he's having troubles going to the bathroom as well, could there be something more significant going on?
Yeah.
Yeah. I mean, it's still the muscle strain could cause him to be unable to really push, but what if he has something else going on in there? Maybe that helped cause a torsion, a twisting of the bowels.
Like pancreas?
Maybe, or what do they call it? Not testicular torsion, but the bowel starts turning on itself,
Oh
choking
yeah.
itself out.
It's like when a cow their stomach rolls or like turns like that, and they have to roll them.
Mm-hmm. So there's a couple of different possibilities, but I would keep on going and whatever else. So that's what I mean about being a robot, and just talk to your patients. Have a normal conversation with them. Show compassion. Okay. All right. You guys have any questions for me?
No.
Okay. We'll still go over stuff on tomorrow. What do we have scheduled for tomorrow?
I think it's a skills day for tomorrow.
Yeah. So I will show you guys. I'll show you guys some videos on patient assessment, the way they do it, and maybe kind of in a weird way, we'll do some skills. I'll have you guys. Rosie, I know Rosie knows some patient assessment, so she can lead. I'll be your guys' patients, or we'll start off, and maybe Rosie can be my patient. I'll show you guys how I do an assessment. I'll continue showing you, and then that way you guys can kind of take a stab at it, and I'll be your patient. And if you have somebody near you, grab them and do like the palpation on them, like your pets. How we say, and it's very true. And I think I told you guys this before. Use your significant others, use your kids, use your relatives, those around you, to practice some of this stuff. And when it comes to the hands-on, that's even more important. Is use them to practice how to do it. I had a 3-foot teddy bear. I don't know how I found it, but I found it, and I took it home, and there I was filling up that teddy bear. So anyway, so we'll do that tomorrow. And as you guys are reading, let me know if there's anything else that you need me to fill in. Okay.
Sounds good.
All right. So.
Sounds good.
All right, guys. Sorry to keep you over. I hope you had fun. I know a lot of you were coming out today, and so that's good. Tomorrow, expect people that are not speaking up. You're going to get called on tomorrow. So we're going to work on that shyness. Okay. As always, please get a hold of me if you have any questions, concerns, comments, anything. I know people have emailed me for some things. I'm just going to eat breakfast because I still haven't had breakfast, and I'll get back to work and I'll start answering all that stuff for you guys. Okay?
Yes,
All right.
sir.
Alrighty.
All righty, guys. Then if there's nothing else, I will see you guys tomorrow.
Y'all have a good day.
Bye, guys.
Have a good one.